Colitis, Ischemic Marie L. Borum, M.D., ed., M.Ph., M.A.C.P., F.A.C.G., A.G.A.F. Joseph Siafi, M.D. Basics Ischemic Colitis, I.C., results from decreased blood flow to the colon with resultant inflammation and tissue damage. Description: more common in the elderly, can affect patients of all ages. Patients present in several ways. Known acute IC from a chronic process with irreversible ischemic injury. Acute IC self-limited. Transient mucosal ischemia. IC is self-limited and reversible in 80% of patients. 20% of patients progress to full-thickness necrosis requiring surgical intervention. Most commonly, ischemia is related to a non-occlusive reduction in blood flow. Presentation varies, but patients with acute IC typically present with localized abdominal pain and tenderness. Frequent loose, bloody stools may be seen within 12 to 24 hours of onset. Second most common cause, 9.24%, of all patients hospitalized for acute lower gastrointestinal bleeding. 1. Laboratory and radiographic findings are nonspecific and must be correlated with clinical presentation. Colonoscopy is the gold standard for diagnosis of IC. In the absence of complications, most patients recover with supportive care including 4 fluids, bowel rest, and clinical monitoring. Epidemiology: female predominance. 57–76% of patients in large series have been female, especially after 69 years of age. 1. Evidence of IC seen in 1 of every 100 endoscopies. Geriatric considerations: rare in patients 60 years old. 70 years is the average age at diagnosis. Incidence: 4.5 to 44 cases per 100,000 in the general population. 1 of every 2,000 hospital admissions. True incidence may be underestimated due to nonspecific clinical manifestations. Prevalence: 19 cases per 100,000 in the general population. Etiology and pathophysiology: local hypoperfusion in the colon compromises the ability to meet metabolic demands. Reperfusion injury may also play a role. Most commonly, an acute, self-limited process. The colon is perfused by both the superior and inferior mesenteric arteries, SMAs and IMAs, and branches of the internal iliac arteries. Occlusion of branches of the SMA or IMA rarely leads to ischemic consequences due to extensive collateral circulation. Watershed areas of the colon, splenic flexure and rectosigmoid junction, are most susceptible to ischemic damage. Blood is carried by narrow branches of the SMA and IMA to these areas, putting them at increased risk for ischemia. The splenic flexure is supplied by the terminal branches of the SMA, and the rectosigmoid junction is supplied by the terminal branches of the IMA. The left colon is more commonly affected than the right. Isolated right-sided disease has the worst prognosis. The rectum is often spared because of additional blood supply from the internal iliac arteries. Type I. Unidentified etiology: likely small vessel disease. Treat supportively. Type 2. Etiology identified: most commonly follows an episode of systemic hypotension, decreased cardiac output, or aortic surgery. Treat the underlying cause. 1. Poor perfusion may result from systemic disease, local vascular compromise, and anatomic or functional changes in the colon itself. An occlusion of large vessels is usually not identified. Hypoperfusion from shock, trauma, embolic occlusion of mesenteric vessels, hypercoagulable states, vasculitis, sickle cell disease, arterial thrombosis, venous thrombosis, mechanical obstruction of the colon, e.g., tumor, adhesions, hernia, volvulus, prolapse, diverticulitis, surgical complications, medications, intestinally active vasoconstrictive substances, medications that induce hypotension and thus hypoperfusion, cocaine abuse, aortic dissection, strenuous physical activity, e.g., long-distance running. Repeated episodes of ischemia and inflammation may result in chronic colonic ischemia, possible stricture formation, recurrent bacteremia, and sepsis. These patients may have unresolving areas of colitis and require segmental colonic resection. Genetics: various coagulopathies have been related to ischemic colitis, including deficiencies of protein C, protein S, antithrombin 3, and factor V Leiden mutation. Genetic polymorphisms have been found in more young patients. Routine coagulation testing not justified except in younger patients and patients with recurrent IC. 1. Risk factors: age greater than 60 years, 90% of patients. Smoking, most common cause of recurrent IC. 1. Hypertension, diabetes mellitus. 1. Rheumatologic disorders/vasculitis, cerebrovascular disease, ischemic heart disease. 1. Recent abdominal surgery, constipation, constipation-inducing medications. 1. History of vascular surgery. 1. History of ileostomy, chronic obstructive pulmonary disease, hypoalbuminemia, hemodialysis, hypercoagulability, oral contraceptive. 1. Immunosuppression, via medication-related affects or cytomegalovirus-induced IC. 2. AAA repair, IMA ligation. 1. IBS. 1. Commonly associated conditions: fibromuscular dysplasia of the superior rectal artery. 1. Colon adenocarcinoma. 1. Diagnosis is based on history, risk factors, and physical examination. 3. A. Laboratory values and radiographic findings are usually nonspecific. 3. A. Colonoscopy is diagnostic. 3. A. History: abdominal pain is the most common symptom. 4. A. Pain may be out of proportion to physical examination findings. Symptoms vary depending on severity. 5. A. Sudden onset, mild to moderate abdominal pain with tenderness over the affected segment of bowel. 5. A sudden urge to defecate followed by passage of either bright red or maroon stool. 5. A lower GI bleeding is rarely heavy. 3. A. Loose, bloody bowel movements may occur, typically within 12 to 24 hours of abdominal pain onset. 5. A. Physical exam: individual signs and symptoms are poorly predictive of IC. 6. A. Vital signs: hypotension, tachycardia, tenderness over the involved segment of bowel. 5. A. Abdominal distension with vomiting, due to an associated ileus. 3. A. In the uncommon setting of transmural ischemia, patients may develop peritoneal signs such as rebound and guarding. 7. A. Differential diagnosis: infectious colitis. 7. A. Inflammatory bowel disease, ulcerative colitis, Crohn's disease. 7. A. Colon cancer. 7. A. Diverticulitis. 7. A. Pseudomembranous colitis. 6. A. Diagnostic tests and interpretation depends on clinical presentation, extent of colonic involvement, transmural involvement, acuity. 3. A CT scan is the initial diagnostic test for patients with nonspecific abdominal pain. 6. A. Colonoscopy most sensitive for diagnosis. 3. A. Radiographic tests and laboratory values are otherwise nonspecific. 6. A. Initial tests, lab, imaging. The following lab markers of ischemia are not specific to IC but can help determine disease severity. 6. A. Complete blood count, leukocytosis. 6. A. BMP, arterial blood gas, signs of metabolic acidosis. 6. A. Lactate, lactate dehydrogenase, creatine phosphokinase, amylase. 6. A. Alkaline phosphatase. 6. A. Albumin. 5. B. Abdominal plain film to look for. 20% of patients show signs of IC such as thumbprinting and mural thickening, may predict worse prognosis. 7. A. Bowel perforation and pneumoperitoneum. 7. A. Abdominal CT scan with contrast. 3. A. The most common CT findings are thickening of the colonic wall and pericolonic fat stranding. 5. Other common CT findings include hyperdense mucosa, submucosal edema, and mesenteric inflammation. 3. A. Pneumatoses, pneumoperitoneum, and free peritoneal fluid suggest advanced ischemia. 3. A. Follow-up tests and special considerations: stool cultures, fecal leukocytes, stool ova, and parasites to rule out infection. 6. A. Patients undergoing aortic surgery may benefit from postoperative colonoscopy within 2 to 3 days to look for signs of IC. 5. A. If indicated, cardiac workup including electrocardiogram, Holter monitoring, or transthoracic echocardiogram to exclude cardiogenic embolism. 6. A drug and toxicology screening. 5. If colon cancer screening is indicated, perform several weeks following recovery from the ischemic insult. 1. Diagnostic procedures / other colonoscopy is gold standard. Sigmoidoscopy used to evaluate postoperative left-sided ischemia. 3. Cyanotic hemorrhagic tissue and edematous mucosa suggest ischemia. 5. Segmental distribution, watershed, hemorrhagic nodules, and rectal sparing. 5. Colon single stripe sign is a single line of erythema, with a 75% histopathologic yield. 5. Routine biopsy no longer advised, as results are typically nonspecific. 3. In cases of isolated right colon ischemia, non-invasive vascular imaging studies are recommended to evaluate acute SMA occlusion. 5. Test interpretation fulminant gangrenous IC seen in 15% of cases requires surgical intervention. 3. Acute transient IC seen in 85% of cases requires clinical evaluation for further workup. 3. Biopsied specimens reveal mucosal infarction and ghost cells, which show normal cellular outlines but lack intracellular contents. 3. Treatment depends on disease severity. 3. Continuous clinical monitoring, including vital signs and serial abdominal exams. 7. In the absence of colonic necrosis or perforation, most patients respond to supportive care. 1. Bowel rest. 5. For fluids to maintain hemodynamic stability. 5. Avoid intestinally active vasoconstrictive medications. 5. Avoid systemic corticosteroids may worsen ischemia and increase risk of perforation. 3. If ileus is present, place nasogastric tube. 3. If radiographic abnormalities present, serial abdominal X-rays help follow improvement. 5. If signs of clinical deterioration are present despite supportive care, increased abdominal pain, peritoneal signs, persistent diarrhea, bleeding, or sepsis, consider surgery. 3. Medication first-line broad-spectrum antibiotics covering aerobic and anaerobic bacteria to avoid bacterial translocation secondary to colonic mucosal damage. 5. Ciprofloxacin 400 mg 4-bid or 500 mg po-bid. Metronidazole 500 mg po/4 TID issues for referral if cardiac workup reveals CHF or cardiac arrhythmias. Initiate appropriate medical treatment. 5. If signs of clinical deterioration are present despite supportive care, increased abdominal pain, peritoneal signs, persistent diarrhea, bleeding, or sepsis, consider surgery. 3. Surgery / other procedures 20% of patients require surgical intervention. 4. Pneumatoses intestinalis, portal vein air, or free peritoneal air are indications for urgent surgery. 3. Surgery may be indicated for peritoneal signs, increased abdominal tenderness, new onset shock, lactic acidosis, or acute renal failure. 3. Diarrhea, lower GI bleeding, or exudative colitis persisting past 14 days. 3. Most common surgical intervention is colectomy with endoleostomy. 6. Cholecystectomy may prevent resuscitation-related acute acalculous cholecystitis. 3. Complementary and alternative medicine. Ginkgo biloba extract has been studied as an adjunct to general treatment weight loss supplements / herbal supplements. Ephedra, mahuang, bitter orange, white willow bark, have been implicated in cases of IC. Admission, inpatient, and nursing considerations. ICU patients represent a difficult population to diagnose IC given the concurrent comorbidities and clinical care, sedation / ventilation, that can mask the characteristic signs and symptoms. Consider bedside colonoscopy in critically ill patients. Ongoing care diet bowel rest until symptoms resolve parenteral nutrition for patients needing prolonged bowel rest who have contraindications to surgery patient education risks of ischemic colitis with the use of weight loss medications / herbal supplements prognosis in most patients, IC symptoms resolve in 24 to 48 hours. Radiographic or endoscopic resolution within 2 weeks right-sided IC is the most significant predictor of outcome. Patients with right-sided IC have a 2-fold increase in mortality and a 4-fold increase in morbidity. 5. Secondary cardiovascular prevention minimizes recurrence. Male gender, low hemoglobin, low serum albumin, high blood urea nitrogen, and presence of metabolic acidosis are poor prognostic factors. 1. Chronic kidney disease, chronic obstructive pulmonary disease. Long-term care facilities increase mortality in IC. 1. Complications 20–30% of patients develop chronic IC, with persistent diarrhea or stricture formation requiring surgery.